Good afternoon. It's truly a pleasure for us to welcome our colleagues from both Iran and Canada to this meeting. Our meeting was initiated by the Sadr Muqaddam, who had the wonderful idea of bringing our teams together. And we are pleased to have with us from Canada, June, with the training and research manager, and we have Professor De Silva, who will be running the training today, and of course he'll be introducing himself. And also we have Justin with us, who's an artist in Canada, will be sharing her experience with us. Thank you all for joining us, and I'm just back to Professor.
Well, I would like to send my warm hello to our colleagues in Canada and say good afternoon to them, and our professors in Tehran and Mashhad and Zahedan. It's a very great honor for us to be here. I'm Dr. Keyvan Mirnia. I'm Associate Professor of Neonatology in Tehran University of Medical Science. In this session, we would like to share our experiences and our guideline, our national guideline, what we prepared in Iran about the instilling surfactant to the newborns and the premature born babies and the term babies. So this is a national guideline what the expert panel gathered with each other, and we made this guideline. For this session, Professor Parisa Mohagheghi from Iran University of Medical Science, she will say this guideline to us, and after that, Dr. Afhaminia, one of our talented students was our intern, will talk about the epidemiology of the premature babies in Iran. So I would like that, and after that, we are waiting we are waiting for our colleagues and professors in Canada. Well, I would like that Professor Mohagheghi start her session. Thanks a lot.
Good afternoon to our Canadian colleagues, and good night to our Iranian colleagues in different parts of Iran. I'm very glad to join this meeting, and hopefully we can work together to better administration of surfactant blessed type in Iran. I would ask Dr. Sadr Muqaddam to please bring my slides in the slideshow so we can proceed to speak about our Iranian National Clinical Guideline for Surfactant Administration that has been approved in 2025, and now we are using it in different cities, and hopefully we can improve it as well.
Excuse me, Professor Mohagheghi, can you share your slides by yourself or not?
I think Dr. Sadr Muqaddam was going to share the slides.
Right, we will try to share it now. We will try to share.
Okay, thank you. Because I'm joining through my mobile phone. In Iran, we usually use natural surfactants that are different types, such as Bless, Corrosurf, Survanta, and Braxsurf. Braxsurf is an Iranian-made surfactant that is very similar to Survanta, and they are mostly from minced lungs or bovine or pig's lungs, and they have surfactant protein B and C. And we usually do not use the synthetic surfactants, and they are not common in Iran. In Iran, we usually have made some proposals to use early NCPAP from delivery room, and try to not intubate the infants in the delivery room. We don't use prophylactic surfactant. And usually we start with early CPAP and use selective surfactant administration as a rescue therapy. In our guideline, it is usually said that we intubate neonates with gestational age of less than 34 weeks when they need more than 30% of FiO2 on CPAP with a pressure of more than 6 centimeters of H2O. Please proceed to slide 4.
Yes.
Indications for surfactant. If the premature babies are intubated in the delivery room for stabilization, we usually give them surfactant promptly after intubation, preferably within the first 15 to 30 minutes of life. We don't use long ultrasound in delivery or NICU wards before surfactant administration very usually. And we are not very familiar with long ultrasound to diagnose surfactant deficiency. We usually use surfactant as early rescue therapy when it is given in the first 2 hours of life. But if for any other reason the neonate is not intubated or doesn't need a high level of CPAP, late rescue therapy is suggested for after 2 hours of life when we have CPAP failure. CPAP failure is defined as more than 6 to 8 centimeters of water of PEEP pressure and more than 40% of FiO2 in the first 48 hours of life. Then we can rule out other causes of distress, respiratory distress, such as pneumothoraxes or air-leak syndromes. And please go to the other slide, secondary surfactant deficiency. Yes, thank you. Primary surfactant deficiency isn't common in infants older than 33 weeks. So if a baby is more than 33 weeks and needs surfactant, it's suggested to consult a neonatologist and then give the surfactant. But in term infants with pneumonia or meconium aspiration syndrome or pulmonary hemorrhage, when they are on invasive mechanical ventilation with low lung capacity and hypoxemic respiratory failure and needing more than 50% oxygen or oxygen index of more than 50%, it is suggested to give surfactant as a rescue therapy as well. There are some centers in Iran that use less invasive or minimally invasive surfactant administration. We do not have the suggested catheter, but we use usually some orogastric tube, number 5 orogastric tube, and put it in the larynx and trachea with a direct laryngoscopy. And administer the surfactant through this orogastric tube. But if there is worsening or persistent respiratory acidosis despite optimal non-invasive ventilation or the baby is not breathing effectively, it is usually some contraindications for LISA administration. We hope we do have some catheters for LISA or missed administration of surfactant, and we are looking for that and asking Bigon company to bring it to Iran, but for this time of the year, we didn't have it in Iran. So as we usually don't use the LISA or missed, or when they are not an experienced person to administer surfactant through these methods, we suggest to use the inshore method. That is intubation, surfactant, and extubation within 1 hour after intubation. And in a lot of different parts of Iran, inshore method is more usual than LISA or MIST. We don't use MAC catheter in Iran because we do not have them. So when we want to give the surfactant intratracheally, we temporarily disconnect the infant from the ventilator and instill the surfactant into the trachea in 2 to 4 aliquots through a small feeding tube. And in between the aliquots, the infant is ventilated with a ventilator or a bag or needle puff. And there are the dosage table for different types of surfactant. Bliss is 5 ml per kg, Braxof is 4 ml, Corosov 2.5 in the first time of giving surfactant, and 1.25 in the second time. Survanta is 4, and Infasof is 3 ml per kg. There are some indications for repeat administrations. If in the 6 to 12 hours after the initial dose of surfactant, the infant still has FiO2 needs of more than 30%, and MAP of more than 8 centimeters of water, then it is usually suggested to give the next dose after ruling out other causes of infant distress, such as Ehrlich syndromes, PDA, or PPHN. And it's usually suggested to consider a neonatologist before giving the second dose of surfactant. And it is not suggested to give more than 3 doses of surfactant. So our key national recommendations are start CPAP as soon as possible, give surfactant if there are more than 30% FiO2 need with a peak pressure of more than 6 centimeters of water. It is suggested to give surfactant through LISA in more than 20 weeks, 20 weeks age of premature babies, and intubate in less than 28 weeks. And if it is needed, give surfactant in 6 to 12 hours after the first dose, and integrate with NICU protocols. Our guideline is revised in 2025, and we have used the AAP surfactant therapy, Cochrane numerical reviews, and national clinical guidelines of other countries such as NHS for revising our Iranian national guideline. Thank you very much.
Well, thank you. Thanks a lot, Professor Mahdi, for your nice lecture. Well, I would like to invite Dr. Afhami. Dr. Afhami was our intern. Now he's graduated. He's trying to make his works and work with our research center. He's one of our talented students, and if you want to know, his CV was the number first in Iran's exam entrance for medical students. Well, he's very proficient in making analysis. He will analyze very, very nice for you. Well, Dr. Afhamini, we are eager to listen your speech, your lecture.
Hello, I'm so happy to be here. Can you hear me?
Yes, we are hearing you fluent and clear and absolutely nice.
Thank you. So I'm Ali Afhaminian, a researcher affiliated with Imam Khomeini Hospital Complex, and recently John Hopkins research position in pediatric pulmonology. And today we are gonna take a deep dive into surfactant usage pattern in Iran. Before starting the presentation, I want to thank Dr. Sadiq Muqaddam and Dr. Mirnia, who made the opportunity possible. We analyzed, in this work, we analyzed about 800,000 admitted neonates, either in neonatal intensive care unit or neonatal special care unit or NSCU, just to see who get the lung medicine. And no, it's not just about getting the lung medicine. It's about the pattern, the access to healthcare or inequalities, and also the trends over the time that we will discuss about. And if you think that I'm so idiot to do this just for this presentation, you think that it's correct. Yeah, I will admit it. So the first part, I will focus on the gestational ages that have received the surfactants. We will look at the data from 2019 to 2022 to understand the trends, the market drivers, and the most importantly, the inequalities in care. We utilized, as I said, the NICU and NSCU National Registry, which is a well-established data set across the country, collects all the relevant data on risk factors, interventions, and outcomes of neonates and also the mothers. Also, the mothers matter. Please look at them also. First, let's take a look at clinical need. You know that we all know that surfactant is a lifesaver medication, but exactly who is getting it? In overall, the surfactant administration rate in Iran is about 8.8%. 8.8% in all admitted neonates for all causes, either in NICU or NSCU. But as we look at the levels of or severity of prematurity, we understand that there is a massive inverse relationship between age and usage. As you see, for babies born under 34 weeks here, for this row, over 34% of these had received at least one dose. It is their lifeline. You see here that 24% received single dose and 9%, 0.39, and have received multiple doses, third dose, second dose, or something like this. And as the gestational age goes up, for example, you see that under 33 to 34 to 37 and upper 37 that we say they are full terms, you see that the surfactant, or better to say no surfactant population is being increasing. It's so realistic because RDS or respiratory distress syndrome usually and normally occurs in premature newborns, and we do not expect them in full terms. But as you see that we have some also multiple dosage in full term. It's probably because that we are not doing redosing for somebody that doesn't have the clinical symptoms. We are waiting until they develop something, for example, respiratory distress or something like this, and then or suspected for sepsis or something like this, and then we go for the first dose of surfactant and then redose it as it needed. So once you cross the 37-week mark, or the babies being full term, the need drops to almost zero. You need here, you see here that we found something interesting about redosing. About a quarter of all babies that get the surfactant needs another dose to end up their needing. The younger the baby, the more likely they are to need the second round or third round or something else. What is the takeaway? The prematurity is the engine that's driving this entire market. If you can predict the preterm birth, you can predict the surfactant demand probably. So also, after we knew that we give the surfactant to whom, we should know that how we get it into them. The first route and the most traditional route is here is invasive ventilation, which accounts for about 52% or 53% of all neonates that have received surfactant. And other than this, for the 5% used insure, which is intubate, surfactant and extubate method, and both of them are some intubation-based methods that are so traditionally, but you know that some new methods have been developed during these days, and it's LISA, mist, less invasive adoption that remains a low prevalence in here. Good news is that the trend toward LISA or mist is being upward, and clinically we're seeing that these trends are getting up further and further. So about the timing of first administration, you know, for example, neurology, they say that time is brain. In cardiology, they say time is muscle. In neonatology, I think time is also brain and also the lung. Our data shows that Iranian doctors are moving fast. 54% of all first doses are given within the first 2 hours of life, as you see here. My slides are stopping yet? No. Okay. And if you extend that to the first 6 hours, we are covering nearly 83%. You see here. You see here. Up to 6 hours, we are covering 83% of all cases. This tells us that our protocols are working well, and we are identifying RDS and treating it proactively. So to put that in somehow perspective, in Tehran, you can get life-saving medications into a newborn's lung faster than I can get a pizza delivered to my house on Friday night. And that is something we should be proud of somehow. However, notice that infants with higher gestational ages tend to get treated later. This suggests that for term babies, we aren't doing some prophylaxis. As I said, we are waiting to see if any sign or symptoms of them getting sick appears, and then make clinical sense, and then we use, for example, surfactants. So let's talk business for a second. Which brands are dominating the NICUs of Iran? Historically, this market is somehow, better to say, oligopoly, not monopoly, somehow oligopoly, that is basically dominated by 3 companies that owned everything, literally. But look at the big dark blue slice of this pie chart, which is about Brexit, that now holds 53% of market share following new sanctions and market shifts in 2020. This national brand took over. Curasurf and Bless are still good players of this game, and they are holding about 20 to 24% of the market share. But everyone else, like Surventa, like others, Infosurf, something like this, they're fighting for create less than 4% combined. So if you walk into an Iranian NICU today, it's basically a coin toss. The heads are Breaksurf, and the tails, you get something else. We talk about the route of administration. I said that it's unfortunately it represents a bit of a traditionalist view of Iranian medicine, and it's mostly because of sanctions, unfortunately. And you see invasive mechanical ventilation, which is the most traditional way, is the king here, with 53% of all the surfactant that is being administered there. So I will a little talk about the trend. The trend, what we mean by trend, it means that over the time, what has happened to surfactant usage, and if there any correlation, or if there any significant change in, for example, time from 2019 to 2022 or not, or just it's an visual hallucination. If we see something going up or coming down, it's just hallucination, or statistics will approve this. So we identified, and everyone knows that preterm birth is the most significant risk factor of using surfactant. So we plotted or make a figure of these two besides each other, in which you can see that the preterm birth is here. The y-axis of preterm birth is here. It's about 14% of all the neonates that's being born under 37 weeks. And here we have surfactant usage. The blues are showing surfactant usage percentage, and the red dotted line are using to show the preterm birth. Okay. I want to show you the most important correlation in this entire study that we've done. Do you see how they move together? Here we have the rate of surfactant age that goes up and the preterm birth that goes up, like they're dancing with each other. It's because the preterm birth, when it spikes, the surfactant usage spikes immediately after. We saw a massive jump in usage from something like 6%, okay, 6% in all the neonates admitted patients, up to here, that is about 11%, okay? It's about twicing. It can be attributable to something like the stress that started after 2020, the COVID, and complications of post-COVID era. Now, on this slide, you can see something scary about the mathematics, some words like Kendall-Toll, p-value, something like this. Here is the non-statistician translation. The math confirms what you see. The link between these two lines is statistically and mathematically undeniable. If preterm birth goes up, we run out of surfactants. It's so simple. It's somehow a good news. I don't know. Anyway, somewhere in here you see, for example, the first spectrum of the time here. I'm in here. That the percentage, or better to say, the preterm birth has been surged immediately, but surfactant is somehow stable and didn't differ along. We did something, we did an analysis on this, on severity of prematurity, and it's a great result that we had find that before the COVID-19, we had less severe prematures. It means between 37 to 34. But after COVID-19, it makes a substantial change and shift into lower gestational ages, and the rates of prematurity, or better to say severe prematurity, rises as COVID-19 begins. Also, this R is the Pearson correlation coefficient, which is about 0.8. It shows the strong correlation between these two plots. It means that they go up with each other, come down with each other, and other things that you know better. Also, we are living in 2025, unfortunately, but our data is up to 2022, and we did a growth forecast up to 2025 to have a better understanding of how surfactant now is being used. So we fitted some models on it. It's a little boring, but some exponential smoothing models in time series could analyze and also feed on our previous data, and then could predict what could happen in the future. But there is a term in time series analysis says seasonality. It means that if your outcome is repeating in some periods in the time or not. And as you see here is more evident that you have some surges here in usage of surfactant. This is what your eyes see, but it could be and it should be statistically evaluated. So we evaluated this. We fitted two models on it, but the first one is double exponential smoothing. The second one is triple exponential smoothing. The terms are not so important. The most important thing is that both of them found a decreasing trend for the future up to 2025. It means that now on, we are talking here, the rate of surfactants should be something near 5 to 7% now. Okay. Also, we have something here. You see, such as seasonality that repeated alongside the time, and this is also accountable in the some series. The most the most useful application of something like this is for sales of some companies, that you can treat your data as see if any positive trend is real or not. Also, residual analysis showed that the seasonality present model is better than no seasonality. These are the facts that we have in our time trend data. Also, we discussed and searched for some regional disparities in here. Here,
Dr. Afkhami, we have 5 minutes time, right?
Yes.
You have to try
Yes.
to finish 5 minutes.
Yes, thanks for reminding this. This final section is perhaps the most concerning. We looked at the map of Iran to see where the surfactant is being used mostly. You would assume that biologically it is the same, right? It's the same. A premature baby in, for example, Toronto would have a same survival chance in, for example, Isfahan. You don't think like that. You don't think like that. But you are, you can admit it, that across Iran, it should not be so different, but it is. As you see here in surfactant usage, we have some provinces with highest rate of surfactant use. For example, Isfahan with about 14%, and how less than 2%, less than 3% usage of surfactant. These disparity, these 7 times difference between these two regions must have a reason. The first reason that could be the real one is the referral pattern of Iran. High-risk moms are sent to specific provinces with better NICUs. It means that probably Isfahan is the referral center for some provinces around this. And the first reason could be referral pattern. The second one, attributable factor, can be defensive medicine, that in some areas doctors might be prescription or over prescribing to be safe. And access is the second factor. In some areas, babies who need it simply might not be getting it. Also, the math shows that a weak correlation exists between these two. What two? Preterm birth and surfactant usage. It's so great. You don't have a same practice across this country. It means that if the preterm birth increases in the time, it would not. It would increase the surfactant usage, but preterm births in one local area would not determine the surfactant usage rate. So this weak spatial positive correlation, which is about 0.30, says that you cannot find any valuable insight from the preterm birth to determine the surfactant usage across the country. But in the time, you can do this. Also, there is no real cluster that we can say, for example, central zone of Iran is getting the most, for example, surfactant usage. This is not real. This is not statistically significant, and this is hypothetically. You cannot say that here you need more, for example, interventions, and you cannot say policy interventions, maybe just a waste of time. You should do it step by step. The key points from here is, or better to say, to wrap this up, let's look at a big picture. Early intervention is winning here. We're getting drugs to babies under 2 hours. This is a world-class standard individualized practice that happens in Iran. It's a very, very great idea and very great performance. The market is concentrated. Nowadays, Braxsurf dominates, and the market is growing due to rising preterm birth rates because of COVID-19, and the gap is real. I mean, we rely too much on invasive ventilation, but the other countries may not. And this 98% of invasive-based methods of surfactant administration may harm the country, may harm and have some costs over than you expect. Also, the geographical disparity between provinces is needed to be more evaluated and the factors to be addressed. So what is our recommendation? We need some national guidelines to standardize when to treat, how to treat, and ensure that a baby in Gilan has the same survival chance as a baby in Tehran. So I'm so sorry if it takes a bit more time, but I want to thank you so much for your attention, and I'm happy to take any questions, whether they are about the statistics and the market, or why I spent 3 years staring at the Excel spreadsheets of birth records. Thank you.
Thanks a lot, Dr. Afkhami, for your interesting lecture. Remind me that now I'm hungry, right? You deliver a pizza, one surfactant with a taste of pepperoni. I'm waiting for you. Thanks a lot.
Yes.
Right. 5 minutes. Do we have any time for the comments, or we invite from our other lecture? I would like to invite Professor Da Silva from Canada. We would like to. We are eager to hear his lecture.
Yeah, you're breaking up there a bit, so.
Hello, Professor. It's a great honor for us to be with you in this session. We all send warm greetings for you from Iran, and I hope you are all right. We are eager to.
Your transmission is fading in and out a bit. Thank you so much, Dr. Murnia, for the kind introduction. I'm going to share my slides. Let's see what. Hang on a second. I'm going to share these slides here. Can you see my slides?
Yes. It's okay, Professor.
Okay. Okay, let me just, perfect. Okay, let me just put a slideshow here. So you can see it. Okay. Thank you so much. It's an honor to be presenting today, and I send warm greetings from Canada as well, though it's not very warm here today. But I do have very great fond memories of the 2 times that I visited Iran, and especially when I went to Isfahan. I thought was the most beautiful, the most fascinating place I ever been to. It's the history and the buildings, and it's just so magnificent. And I'm very grateful and for having had that opportunity. And what I'm going, can you see this, the technology? Can you see these slides? They don't seem to be moving. Hang on a second.
Yes, we have your slides.
Okay, let's see. But they don't seem to be moving. Okay, let's see what's going on here. I'm trying to move and they are not moving. I'm going to stop sharing and share it again. I don't know why they are not present. I'm going to stop sharing and I'm going to do it again and see if we can, if they can.
Professor, do you want that you send it to us and we share it with you?
Let me try just once more and see, because
If you can, you send to Dr. Homam, then she will share it for you.
yeah, let's see if
All right, we're waiting.
okay. But for some reason, yeah, you can see, but I can't move this light for some reason. Let's see. Okay.
Well, I think it's because of the cold. It's
Did it
colder.
move now? Okay, okay. I think it's working now. Again, as I said, thank you very much. What I'm going to do, I'm going to present our experience with surfactant, talk about some of the Canadian guidelines, and I really appreciate Dr. Afkaminian and Dr. Mohan Gaggi presenting, and that gave me a good background and a good sense to see and have an idea what is going on in Iran, so I can have a sense. And I'm going to focus on Miss Lisa, and I noticed from Dr. Ali Afkaminian presentation that only less than 2% of the surfactant administration in Iran is via mist, laser mist. And if I say laser mist, it's the same thing. The terms are interchangeable. And I'm hoping that at the end of this presentation, I'm going to convince enough of you to switch to laser administration. I'm going to show you the literature that will hopefully convince you. Nowadays, in my unit, actually, it's the other way around. The more than 90% of all the surfactant administration, we use the mist method. And in Canada, it's been increasing more and more in Canada, and more units are doing it. And the mist method in Canada is more than ensured, and through the endotracheal tube. And I'm hopefully, as I share the literature with you, I'm going to convince you why we move that way and why that's the way of the future. But just to starters, I know different countries have different rates of mortality and different healthcare system, and it's all different. But I just want to show you what is the state of the art today in Canada as far as survival is concerned, and the limits of viability and the type of patients that we get in our unit. We have the Canadian Neonatal Network, which collects data across Canada. They've been doing this for almost 20 years. And every year they published all the data from across the country. And that way we all know which hospital, how you're doing in relation to the other ones. And as Dr. Afkaminian mentioned and presented, that mortality in Tehran or in Esfahan is different. In Canada, it is different as well. Some units do better than others, but in general, it's relatively more similar than would be in other countries, because we have a very universal healthcare system. It's very unified, and we share data across the units so we can learn. Just goes to show you that nowadays in Canada, babies less than 23 weeks, we have a 30% survival. At 24 weeks, we are at 50 to 60%. At 25 weeks, 80% survival. 80% survival, and most of those babies beyond 25 weeks will survive and survive well. At 26, 27, we are well above 90%, as you can see on the graphs here. It's quite impressive, the survival rates, even for the very tiny baby. To the point that we used to have a limit of viability below which we would not offer a resuscitation. Nowadays, we no longer have that. It is a decision made by the parents. If you have a 20, you see, I'm on my scrubs. I am on service this week in my unit. I have a 52-bed intensive care unit, and I have a couple of babies, 22, 23 weeks. So the family that decides if they want to go ahead and resuscitate or not, we assist them and we navigate them through that. As you can see, if you have that many very tiny babies, there will be a very high need for surfactant. there's I can feel some echo. I don't know why, but so there's a high. So there's a high. If someone could mute the, if anybody's not muted, for some reason I am getting some echo. Dr. Mirnia, if you could.
Professor, your voice is
If you could.
I can hear you, but we have a little bit trouble with your voice. I think I don't know what happened.
Can you mute your microphone, Dr. Mirnia, so to see if that gets better? Yeah. Okay. Is it better now? There is no echo. I think because your microphone was open, Dr. Mirnia. I think that's the reason why I was having some echo. So just goes to show you, because of this survival of very tiny babies, the need for surfactant is significant, as you can imagine, because RDS, respiratory distress syndrome, is inversely correlated to the gestational age, meaning that the more premature the baby, the higher the rate of respiratory distress syndrome. That's the survival by gestational age, and just the survival by birth weight. And it's highly, the two variables are highly correlated, as you can imagine. So babies less than 750 grams, we still have a 60-70% survival, which is quite impressive in Canada. It's quite nice to see the survival rate so high. And so I put that slide just to show you that, of course, different countries have different survival rates, and different, even in Canada, within Canada, different units have different survival rates. And as I said, and as Dr. Parisha presented the guidelines from Iran, they are not that different from ours. The criteria is very similar. The only difference is that we use way more list and mist than you folks do. And that's why I'm going to focus today mostly on the scientific evidence to support the use of mist, and walk you through the experience that we've had in some of our own local data. We've published quite a few papers on mist, Lissa, in our unit, and we have developed quite an experience. We started doing it in 2016. And as I mentioned to you, nowadays a baby comes through our doors, regardless of the gestational age, regardless of the birth weight. If the baby is on CPAP or non-invasive ventilation and IPPV and clinically well, no evidence of sepsis or no hypotension and no issues and no need for intubation right away in the resuscitation room for many issues, because premature babies may need to be intubated right away for a number of reasons. If that baby is breathing spontaneously, we'll use mist as our method of delivering the surfactant to this baby's lungs. And I'm going to show you why we do that and what's the evidence behind that. And let's start by showing you this slide. And the reason I want to show you that slide, because there is good data from Alan Job showing that even very brief mechanical ventilation, either with a neopuff or bag and mask ventilation or mechanical ventilator on an actual ventilator, even a few puffs is sufficient to start the cascade of lung injury that's going to end up with chronic lung disease. As you can see on this slide, on the left side, the top left image show the lung that seems okay, seems fine, and the bottom right shows a lung that's severely injured. That's a lung that was injured through mechanical ventilation. And there is a strong correlation between mechanical ventilation and lung injury in the preterm baby. So that correlation is very strong. If we do need to give surfactant, as was mentioned before, it saves lives. No question. Surfactant has had a huge impact in neonatology, and surfactant does saves lives. Mechanical ventilation also saves lives, but mechanical ventilation has some nasty side effects, which is lung injury. what about if I could give surfactant, but without having to intubate and mechanically ventilate the baby? So be ideal. Of course, the ideal be to deliver surfactant completely invasively using nebulization, but that technique and that technology is not here yet. We cannot do it yet. It's not available yet. It's still under study, and the delivery methods are not good enough to justify the use. So let's do the second best thing, which is deliver surfactant without having to intubate the baby. And I'm going to show you the scientific evidence that will strongly support that. And I'm hoping that at the end, in a few years, when we talk again, instead of less than 2% of babies receiving mist in Iran, we have a much higher proportion of babies that will be receiving surfactant using the LISA mist technique, as opposed to either the Ensure, which is still intubation, or mechanically ventilated babies. Of course, some babies we do. So let's talk just a little bit about the Ensure. Ensure is a great method. It is an advance comparing to an intubated baby and leaving the baby intubated. The idea is to intubate surfactant and rapid extubation. Would be for surf or rapid extubation. But what happens is quite often these babies are intubated in the middle of the night, and we leave the baby intubated until the morning. It's a weekend, the unit is very busy, and you end up ventilating the babies longer than we have to. And by doing that, we end up with some more lung injury than is necessary. So the idea is to keep these babies off the ventilator. So it was published way back in the first study was published way back in 1990, and is a great technique and works well. Okay. What about non-invasively? This is a report that I always like to show, was from Scandinavian countries in 1992. They were doing a pilot study with the Ensure method, but they do describe in the abstract that 2 babies received surfactant using a feeding tube without having to intubate. Instead of intubating to deliver the surfactant, what they did, they delivered the surfactant through a feeding catheter. And that was quite interesting, went largely unnoticed because it was published in Danish and was published in a very local, obscure journal. So nobody really paid too much attention to it. But Dr. Angela Merkel in Cologne, Germany, she did pay attention to that, and she noticed that, and she said, "Oh, that's very interesting." And she started doing it. In 2007, she published her case series, and it was not randomized, was not a randomized trial, but it was a before and after historical controls, and she started using it. She thought, great idea, the baby's on CPAP, early CPAP, exactly like what we do, the guideline in Iran, we start early CPAP on these babies, or early NIPPV. Some units in Canada, our unit started early NIPPV for babies less than 30 weeks, and CPAP for babies more than 30 weeks. And other units in Canada start mostly on CPAP, but we do start early NIPPV on a very tiny baby. And so she said, well, babies on CPAP doing well, not septic, not hypertensive, no other clinical issues other than prematurity, but the baby has good respiratory drive. Why not deliver the surfactant using a feeding tube? And that came to be known as the Cologne method for the city of Cologne in Germany, where Dr. Angela Merkel, Angela Krebs, Angela Merkel was the prime minister of Germany, is Angela Krebs, where she works, and she used a feeding tube and delivered the surfactant, and differently from the Ensure or deliver surfactant through endotracheal tube that usually give 1 or 2 boluses, rapid administration surfactant followed by positive pressure ventilation. In this technique, you place your feeding tube in below through the glottis, below the vocal cords, and you close the mouth and you administer the surfactant, use microboluses. Can take thing can take you 1 to 3 minutes to deliver, because you're going to take advantage of the baby's spontaneous inspiratory movements. So there is good data showing that if the baby is breathing spontaneously, you can deliver surfactant more effectively to the distal airway and more uniformly to the lungs than if I push it using a bag and mask or even a mechanical ventilation. Because you in your case, you disconnect. You guys don't have the Mach vent catheter that we using a side port. We deliver the surfactant while the baby's on mechanical ventilation. You disconnect and administer surfactant in bag, so the surfactant can be distributed unevenly through the lungs. But if I deliver the surfactant with the baby breathing spontaneously, the probability that surfactant is going to deliver more uniformly is much, much better. And it is delivered slowly. So volume is not an issue. Whether you use 4 per kilo, 5 per kilo is irrelevant. You want a surfactant that has low viscosity, and like the blast surfactant that you do have in Iran has a low viscosity. So it's a surfactant that very quote unquote liquidy, meaning that it does flow nicely when the baby is breathing spontaneously and when you are delivering that surfactant to the baby's lungs. So it is a great idea. She published that data, and it creates a lot of interest across the globe, especially in Europe and Asia, and Australia and New Zealand, and Canada sent a team to Germany to learn that technique. So it's quite interesting that created a lot of interest in the neonatal community. And since then, since that paper was first published in 2007, I believe, 2007, a lot of other truly randomized trials were conducted. A number of them was done in Australia, New Zealand, Europe, and other countries. A number of studies were done. And that data was combined in 2021 by Dr. Dagarville from Australia and his group, and published in the Cochrane Library of Systematic Reviews in 2021. And the results were quite impressive. What they did, instead of a meta-analysis, you folks are familiar with meta-analysis, this forest plot graph way of showing the data. What do? You get all these smaller studies, combine them, and as if you make one big, large trial. When they combine all the studies, the smaller sample size, they end up with over 660 babies on each group. And the advantage of that, because you have enough power, meaning that you have enough representation to show you results. So what he did, he said, okay, let's have a look. When you compare surfactant administered using mist technique compared to the Ensure technique, let's see what happens to death or bronchopulmonary dysplasia. Let's combine those two outcomes and see what is the result. And impressively, what it showed, what it did show, yeah. What can you still see this slide? Is that okay? Can you see this slide?
Yes,
okay.
We can see it. Yes, we can see it.
I just make it a little bigger here, so now it's better. So what it showed, that when you combine death or BPD, the two outcomes, the odds ratio, the risk ratio was 0.59. What that means, there was a 41% reduction in the combined outcome of death or BPD. Now, we all neonatologists here, just tell me, in your unit, in my unit, in any country, what can we do in our unit, a relatively simple procedure? If the babies need to get surfactant, I need to deliver the surfactant to the lungs. All I did is deliver using the Ensure technique or using mist, and I reduced death or BPD by 41%. I am not aware of any intervention in the current neonatal practice that is going to give me that kind of results. I'm not aware of any. So 41% reduction in the combined outcome of death of BPD just by delivering surfactant in a different way as opposed to the insured technique. And it was quite impressive, those results. And then he asked, okay, I know that when you combine death of BPD, there's an incredible reduction in that bad outcome. Both of them are pretty bad. Death is not good. And BPD is very nasty and causes lung problems and all kinds of issues later on. What about is just BPD? Let's look at just BPD. So the odds ratio was 0.57, meaning that there was a 43% reduction in bronchopulmonary dysplasia. Bronchopulmonary dysplasia is very nasty, as I said. 25% of babies with bronchopulmonary dysplasia end up with pulmonary hypertension, then end up with heart failure and other issues, and increased mortality after discharge from hospital and after these babies go home. BPD is very bad. BPD with pulmonary hypertension is even worse. So it is a very nasty outcome, and it is a side effect of mechanical ventilation and management in the neonatal units. So just by using a different technique of delivering the surfactant, there is a 43% reduction. What about just death? Just look at just death. They looked at death and BPD, and then look at BPD by itself and death by itself. So the odds ratio was 0.63, meaning there was a 37% reduction in mortality. Just tell me what we do today in my unit, a simple, relatively simple intervention that's going to reduce mortality by 37%. I'm not aware of anything that I can do today in my unit that's going to reduce death by 37%, but just using a different technique of delivery surfactant. So those results are very impressive, and those results are very convincing, and those results should really be taken very seriously, because it is no question of a fantastic outcome for advancement in neonatal management. What about need for mechanical ventilation? The odds ratio 0.63. So there is a 37% reduction in need for mechanical ventilation. Probably that explains why you have less BPD, why you have less bad outcomes, because you're going to reduce the need for mechanical ventilation. And I'm going to show data from our own unit showing you how successful we've been maintaining these babies on CPAP without needing mechanical ventilation. I've been around for a long time, and I started my training in neonatology in 1985. And in the 90s, I would walk into my neonatal unit. If I had, say, 20 babies that needed needed ventilatory assistance, 17, 18 of them were mechanically ventilated, 2 or 3 on CPAP. Now is the reverse. Now is the opposite. I would have of 20, 25 babies that need respiratory assistance in my unit, 20 of them will be on CPAP or NIPPV, non-invasive ventilation, and only 5 or 6 on mechanical ventilation. Of course, there will be some babies that need mechanical ventilation, surgical babies, very tiny babies, and all kinds of things. There will be some babies that still need mechanical ventilation. But the majority of the babies in my unit today, they are on CPAP or NIPPV, not on mechanical positive pressure ventilation. So just to show you, need for intubation within the first 72 hours. And there is data from other sources as well showing that need for mechanical ventilation anytime during the NICU, when you use the MIST technique, there is a reduction. So just good. I hope that data is very convincing. It was very convincing to the Canadian Pediatric Society and also the Cochrane Library, that said that if you're going to give surfactant to a baby that's breathing spontaneously on CPAP or NIPPV, you should prefer to use non-invasive or less invasive surfactant administration technique that Lisa missed, because the evidence is so clear and the evidence is so compelling that a stable baby that is only problem is prematurity and RDS, that baby should receive surfactant non-invasively. And that baby, we should prefer that over intubation and the insured method. So that's the Canadian Pediatric Society put out that position statement that the neonatologists in Canada should prefer that way of delivering surfactant as opposed to the insured method. Okay. I'm just going to walk you through a little bit through our unit. For the folks in Iran that are not yet familiar with the technique, my suggestion that you take a step similar to what we did, because what happened in Canada in 2013, after a group of neonatologists went to Germany to learn this technique, they came back and tried to do very tiny babies and failed. So they stopped doing it, and nothing much happened. And then 2016, I was aware of the literature, and I wanted to introduce the technique to my unit, but I waited until I had the perfect baby. So we started with babies that were 28 weeks and above, or 1 kilo and above, and were clinically well, and we started the MIST technique. Initially, we started with a feeding tube that, like everybody else, we started with the feeding tube, because I wanted to make sure that every time you start a new technique and you're going to find resistance, a lot of people is going to be resistant to change, and you want to make sure that you maximize your probability you're going to be successful. And success breeds success, the same as failure breeds failure. Because if I had failed initially introducing this technique, we would not be where we are today. And so I trained a small team, and I trained a very small group of people, and we are just us that would do them. And then as the unit became more familiar, and we've been more and more successful with bigger babies, more than 28 weeks, more than 1 kilo, and then we kept going down gestational age. And initially for sedation, we use only sucrose, and then an atropine to reduce the probability of bradycardia. So we use atropine and sucrose, and then in 2017, we introduced a small dose of fentanyl, and you have to be very careful here, because if you give a high dose of fentanyl, we may get into trouble because the baby will be overly sedated and have apneas due to the opioid that we gave. So we gave a very tiny dose, a short life. Fentanyl has a very short life, very tiny dose. So just to take the edge off of the laryngoscopy procedure, which is uncomfortable for the baby. And we also, the other thing that we do is not as much as a pre-medication, but it is to reduce apneas and increase the probability of the baby staying off the ventilator and staying on CPAP and IPPV. We do caffeine very early on, very early. The baby is born, and as we are getting lines in, the nurses get a peripheral IV. Another nurse is already preparing a loading dose of caffeine, and we give the caffeine very quickly. So we use early caffeine and atropine and fentanyl. And to this day, that's what we use for our pre-medication for LIST. So as we went over the years and gaining more experience, so we went for more than 28 weeks and then more than 26 weeks, and we kept you gain experience and become more comfortable with the technique, and more people are buying into it and being convinced. And as I said, success breeds success. And as the other neonatologists and the nurses and the respiratory technologists, seeing that how successful we were, we went down on gestational age, and we kept going. In 2020, there was a development of a video laryngoscope that helped to become more proficient, because we have a big unit with a lot of trainees. For experienced intubators, a neonatologist has a lot of experience intubating. A video laryngoscope doesn't make much of a difference, but because we have a lot of trainees, a lot of fellows, and with different levels of experience, the video laryngoscope is very helpful. It's technically easier for them, and also we can use it to teach as they are during the laryngoscopy, you can show them the anatomy and makes it easier. Also, the other thing that we tested and used here after Daggerville published his paper was using the angel cath, because if you use the angel cath, we don't need the McGill. You don't need the McGill to introduce the feeding tube through the trachea. So you use the angel cath. It's a little more, it's firm, but the problem is it's a little too stiff, and we use it, but we didn't like it as much. But luckily, in 2021, a purpose-built mist catheter became available. One from Blast Biochemicals that has a catheter, and also a company from Europe called Vigon develop a catheter as well. And that way you don't need the McGill forceps, and it's a lot easier. And because the feeding tube, it can be a challenge to pass it through the larynx. Not only that, but when you pull your laryngoscope out, because you have to pull the laryngoscope out, pull your McGill out, and close the mouth and let the baby breathe spontaneously with the mouth closed as you give the surfactant microboluses over 1 to 3 minutes. Sometimes when we pull the laryngoscope out, the catheter came right out with it. And if you have these purpose-built catheters, it's great because they are firm and they stay in place. They're small enough that you can give the surfactant, but they are also firm enough that you don't need the McGill forceps to introduce it. And we obtained better quality video laryngoscope, and things just increased, and we got better and better. And in 2023, we removed any exclusion, gestational age and birth weight. Now in my unit, a baby comes, could be 23, 24, 25 weeks, whatever week it is. If the baby is clinically well, breathing spontaneously, on CPAP or NIPPV, no hypertension, no other issues, and breathing spontaneously, we load them up with caffeine, and then it's an oxygen, and the oxygen is and you make a diagnosis of RDS with either radiological, even clinically. We don't use, as was mentioned by Dr. Sarisa, we don't use lung ultrasound. We use lung ultrasound only for research purposes, but we don't use lung ultrasound to diagnose RDS. If the baby has a clinical picture, premature, oxygen going up, indraw and grunchy, we go ahead and give surfactant. So nowadays we no longer have a weight criteria. We no longer have a gestation age criteria. We have clinical criteria. If the baby is clinically well, there is no need to intubate in the resuscitation room. We go ahead and do mist. So now our default, the vast majority of our babies, very unusual for us to intubate. We don't do insure anymore. We don't use insure technique anymore. Of course, if the baby needed to be intubated for other reasons and has RDS, yes, we will give surfactant through the endotracheal tube, absolutely. But we do not do insure anymore because we use the mist technique. And we published another paper in 2022, we collect data in 2021, just showing that, as you can see, from 2013, when it was first used, and then they stopped using it, and then 2016 we started, and then nowadays we have data in Canada, and most units, even the level 2 units, are adopting this technique, and it's going really, really nicely. And most units in Canada are using the mist technique, the vast majority of them. And for the vast majority of babies, that's how they are delivering surfactant. And then this is a graph just to show you the kind of patients that use mist. We do mist at all gestational age, from less than 24 weeks up to more than 34 weeks. Some people make an argument that is potentially valid, that maybe you should do mist on smaller babies, but not on bigger babies, because they have less BPD, they are less likely to die, and they are bigger and fight. But we don't find it. We give mist in every gestational age that needs surfactant, obviously. If I have a 35-week that has RDS and needs surfactant, yes, we do. That's how we do. We do mist. If you have a 25-week, a 24-week, the same. So we do on everybody. But the vast majority of babies have RES is somewhere between 26 and 32 weeks. That's the vast majority of babies that's going to develop RES and need surfactant. Okay. This is data that we are in the process of. We looked back on our data, and we published a few papers on the technique, and we looked back on our data just to see if we could predict the babies that fail missed. And we had our cohort was 219 babies, and the mean gestation age was 30 weeks and 1.7 kilos at the mean birth weight. And what we found that when you give mist and using blast as surfactant that we use here in Canada, most of the units in Canada, 80% of the units in Canada use blast, and in our unit we use blast because the company is here in London and is a high quality product. So we found that after we give mist, more than 50% of all the babies were weaned to room air within an hour. So you go from whatever amount of oxygen you are on to room air within the hour. And what percent of failed? 19.2% of babies failed mist. And by that, the definition of failure of mist was needing mechanical ventilation, intubation and mechanical ventilation within the first 7 days of life. Some of these babies failed due to sepsis. Some fail due to lung problems, and we did not look at the individual patient to see why they fail, but we do know that 20% of the babies needed to be intubated. And the other thing that I want to know is what is criteria, what can we use to try to predict the babies that fail? What we found that babies that were still on more than 26% oxygen at 1 hour or 6 hours, those were more likely to fail mist. Of the 19% that failed, and if they were on more than 26% oxygen at 1 hour and or 6 hours of life, they were more likely to fail than the ones that were on less than 26% oxygen. And just goes to show you that if you have a baby on CPAP or NIPPV, and we have babies of all sizes and very tiny babies and a lot of very small babies, 20% needed mechanical ventilation within the first week of life is pretty low, meaning that that goes to show you what I said before, that now you walk in my unit and the vast majority of my babies are on CPAP or NIPPV, not on mechanical ventilation. Only a small percentage of them would be on mechanical ventilation. And so what's the take-home message of MIST? It reduces BPD, reduces mortality, reduces need for mechanical ventilation. And I did not show you the data, but there is good data from long-term outcomes from Germany and from Dargarville from Australia, showing that they reduce later hospital admission at 2 years of age, especially related to respiratory issues. There is a significant reduction. And there is a possible improvement in neurodevelopment outcome. The data is still not out there yet, and there is some data in Germany. They're following this patient to see because they have less BPD, and also there is good evidence out from Dr. Englert-Krebs and also the Cochrane Library that I did not show you. There is a reduction in intraventricular hemorrhage if you use the MIST technique as opposed to the INSURE technique, and potentially you can improve long-term neurological outcome. And then, of course, it's going to reduce cost of care because taking care of a baby that's intubated ventilated is a lot more expensive than taking care of babies on CPAP. In my unit, the baby has mechanical ventilation, especially in the first week of life, is 1 nurse per baby. But if the baby's on CPAP, could be a nurse for 2 or 3 babies. So it's a lot cheaper to look after babies that are on CPAP than babies on mechanical ventilation. And just to touch upon on other methods, less invasive methods of surfactant administration. Yes, laryngeal mask are a way you can use. There is some data in meta-analysis showing that it works on some babies. The limitation is because of the size of the mask, the babies need to be bigger. more than 1.5 kilos because of the mask will not fit properly if the baby is too small, and you may not be 100% certain that the surfactant went into the larynx. If you using the laryngeal mask airway, some people have used it to guide the introduction of the mist catheter through the laryngeal mask, and as opposed to using the McGill forceps or the laryngoscope, use the laryngeal mask to guide the introduction of the mist catheter. And of course, nebulization would be ideal, but as I said at the beginning, we don't have data yet to support that we going to use nebulization. Is not, they still under investigation. And there's some data showing pharyngeal surfactant instillation just by instilling surfactant in the nasopharynx. Some of it is going to end up, the baby is going to aspirate some of it into the lungs, and it may help if you are in an emergency, if you are in a place that nobody can intubate, and you can use that, either laryngeal mask on a bigger baby, or even drip a surfactant in the nasopharynx. But of course, an expensive product like the surfactant is, you want to make sure that you put it in the lungs and where it's supposed to go. And just quickly mention the other indication of surfactant therapy in the term and late preterm infant. In meconium aspiration, we use, if the baby is intubated, ventilated, and very severe meconium aspiration, we try, because the meconium may and will deactivate the protein in the meconium, will deactivate the surfactant in the distal airway, and you may have a secondary surfactant deficiency. We do give a dose of surfactant. Quite often doesn't work that well and is disappointing the results, but we still try. Some babies do respond, some babies don't, some respond just a little bit, but we do try. The other one is pneumonia, the same mechanism of secondary surfactant deficiency. In cases of idiopathic pulmonary hypertension, we try to see if it helps. Quite often it doesn't, but it may help some babies. But one thing that I just put there, congenital diaphragmatic hernia, we do not give surfactant to babies with congenital diaphragmatic hernia, because the data has shown that if anything, it makes things worse. So just a caution you, if you're giving surfactant to a congenital diaphragmatic hernia, not to because it does, the data says that it will make things worse, not to we don't. But we do meconium aspiration, pneumonia, pulmonary hypertension, pulmonary hypoplasia. Now the one that I forgot to mention, to add there, but pulmonary hypoplasia, quite often pulmonary hypoplasia comes with prematurity, and we do attempt at those. But in these things, because it's secondary surfactant deficiency, quite often it doesn't work as well as we would have liked. Okay, and I'm just going to show you a little bit of I already showed you the survival, and this is just the survival over the years, just to show you less than 23 weeks, how at the blue line, less than 23 weeks, how even back in 2012 and has gone up to around 40%, less than 23 weeks. At less than 23 weeks, the blue line, the red line is 23 weeks, see 60% survival, and at 24, and at 24 weeks, almost 70%, 25 weeks, 80%, 26 weeks, 90% in 2023, and how the survival in Canada is pretty good. And that's why we have a lot of premature babies that we need surfactant. And if they are clinically stable, and if we do use the MIST technique, a lot of these babies is going to be even much better and reduce BPD. 27 to 32 weeks, of course, the survival is very high. 27 weeks, more than 90%, and almost 99% at 32 weeks. So survival and intact survival is gestational age dependent. Every week makes it better and better and better and better. Okay, chronic lung disease. Just this is data from 2023, just to show you that despite all our efforts, the babies still have have immature lungs, and the tissue of the lungs is immature. At this very moment, I have a baby in my unit that 22 weeks has horrible lungs, going to end up with severe BPD. Again, the BPD is associated, inversely associated with gestation age. The more immature you are, the higher the probability of develop BPD. And surfactant does not have a lot of effect on that, but the technique of mist reduces that risk. They still have a risk, obviously, but if you use the mist technique, going to reduce that risk of bronchoporine dysplasia. And just by birth weight, the same. And this is over the years, how bronchoporine dysplasia, we are saving more babies, like, and you can see the 23 weekers, how they have, because they used to die in the past, now they're surviving, so they are more susceptible. And these are the babies that tend to fail, miss the most, the 24, 23, 24 weekers, although we do try missed on a baby that is stable at 24 weeks, even at 23 weeks. But most of the time, they are intubated, ventilated, and get surfactant on while they are still intubated and ventilated. Because they just, in addition to the immature lungs, they're immature everything else. They don't have the drive to breathe, and they need assistance. Okay, so they are the ones. Of course, a more mature baby, no, they will be fine and they will survive. And over the year, the survival rate is pretty impressive. I want to thank you for the opportunity to share our experience with you, and very grateful. And this is the camp of my university.
Thank you very much for your impressive lecture, Professor Da Silva. I would like to remind that 13 years ago, my dissertation in fellowship for neonatology was missed in Tabriz University under supervision of Professor Heydarzadeh, that is attending in the session today. I remember when I was presenting my dissertation, one of the referees asked me that how your studies showing very low BPD. Then I said, well, this is the technique. Then he said, I don't believe to that, because if I believe such a thing that one thing can bring the reduce the BPD, we have to give Nobel Prize. Now I'm seeing your lecture. I am very impressed because of your results that you could reduce the BPD. And 12 years ago, I said this, but unfortunately they said that it's a little bit crazy. Well, thank you very much, Professor.
Welcome. Thank you.
In Iran, we are using mist in Tehran University. Professor Sadegh Muqaddam is using this technique, and I know that in Tabriz and in some parts of Iran, they are using it, but we have some problems because of the.
For some reason, we cannot hear you.
Yes. Thanks again because of your attendance in this session. I would like to invite from Josine. She's a respiratory therapist. I think she's from Canada too. I would like to see her and hear her lecture. Thank you, Josine.
Hi.
Hi, how are you?
Good, and you? Thank you so much for having me today.
Thank you. We too.
I'll just ask Huma. I think she's sharing my presentation.
Your presentation, we don't have your presentation. I don't know. Does your operator have over there in Canada?
Yeah, Huma. Let me know if my screen appears in the sharing.
Yes.
You have the presentation? We have it.
Yes, I do have it.
Josine, we don't have your voice.
What's that?
I think you're mute.
You think I'm muted? Can you hear me?
We can't hear you at all. Josine.
Okay.
We can't hear
I
at all.
just want to go.
I think you mute yourself.
Can you hear my voice now?
Yes, we can hear you.
Okay.
Yes.
Very good.
Your slides, but we don't have your voice.
Dr. Minia, we can hear Jocelyn, but you can't hear. Her voice is very fine.
I think everybody can hear, yes. From what I'm gathering.
Excuse me, we don't have your voice. Can you check your speakers?
Dr.
No,
Hermia. We can hear her very fine.
yes, we can hear her in Canada here too.
Kevon, did you reduce your sound by any chance?
Homa, can you hear Josiane?
سلام دکتر خوبی؟ داری؟ خب ما نداریم. آها باش. Right. Merci. Josine, I think that they are saying that we have your voice. I think you can go on.
Okay, perfect. Sounds good. So my name is Josiane. I'm a respiratory therapist here in Canada, and I have been for about 8 years now. So I just want to share with you a short presentation and introduction on what is a respiratory therapist. So just a quick outline. I'll talk about what is a respiratory therapist, quick debrief on like just education. Where does an RT work? What kind of patient do we see? What kind of therapy do we provide? And I'll elaborate in the respiratory therapist in the NICU. So the respiratory therapist is a regulated healthcare professional who works to evaluate, treat, manage cardiopulmonary disease and other conditions such as NRDS in the NICU. So we work with all kinds of patients from neonates all the way to adults. There's been a respiratory therapist in Canada since 1964, but in the United States, it was as early as the 1940s. So we have to complete a 3-year college or university program to become a respiratory therapist, and this includes clinical training. It's quite extensive training clinical training to prepare for this job. Upon completion of the schooling part, you have to complete a board exam, so the Canadian Board for Respiratory Care. And once you have completed your exam, you then have to obtain your provincial registration and license to be able to practice. So RTs work in many different places. In the hospital, if there's inpatient, an RT will be covering that area. But there's also clinics and community where there's also RTs. So I'll use RTs as a short version. So there are a lot of RTs that most RTs in fact work in the hospital because it's a very critical care program that we are prepared for. So you'll see RTs in the NICU, in the adult intensive care, emergency department, operating room, and such. So just a little bit of a patient profile for the NICU portion. So we'll care for a lot of different neonate patient with various different disease, but that requires respiratory support. So from prematurity, NRDS, TTN, PPHN, meconium aspiration syndrome, and so on. In the adult and pediatric realm, we care for people that have all the way from asthma to COPD or pneumonia to like stroke and traumas and neuromuscular disorder. So it's a very broad range of support that we bring specifically. So there are multiple different roles throughout the hospital for RTs. So just to name a few, because there's many more, I'll just name some of the most important, and that relates to the NICU as well. So we are either performing or assisting the doctors for intubations. We do surfactant administration. We initiate and manage the mechanical ventilation. We monitor the pulmonary mechanics, initiate and manage nasal CPAP or BiPAP or NIPPV in the NICU. And also high flow oxygen and many other things. So in Canada, we have respiratory therapists covering NICUs 24/7. So 24 hours a day, 7 days a week. And we receive care handover from one shift to another for our patient. In the level 3 NICUs, which are the highest NICUs in Canada, so treat extremely low gestational age, so like 22, 23 weeks. You usually have at least 2 RT covering or more, depending on the number of beds. And there is an office for RTs in the NICU because we need to be readily available for neonates that possess. And in these unit will provide like, the high flow, non-invasive respiratory support, as well as invasive, so mechanical ventilation, high frequency ventilation, or jet ventilation, which is managed by the RT under the hospital's protocol. In the level 2s, which is typically over 30 weeks gestational age, you'll have one RT that is also situated within the NICU, that has an office within the NICU, or in close proximity to be readily available for any neonates that requires our service. And these units provide as well high flow, non-invasive respiratory support and mechanical ventilation managed by the RT under the hospital protocol. So just like all of you do in your unit, the respiratory therapists, like the nurses, we will do a full chart review on our patients. We got a shift report, but we'll review all the history, the vitals, the blood work, the x-ray, the medication, because although we're trained in specifically respiratory care, we know that we have to treat the patient as a whole and that many different things can impact respiratory breathing. So we'll do a full patient review and we'll do our bedside assessment. So and we make sure that our endotracheal tube is well situated, that it's well secure, our nasal CPAP as well. We make sure that we're getting good pressure, looking at our ventilation support, our mode, our 5-2, our PIP, and collecting all of this data. And we're going to adjust the settings based on what the feedback we're getting from the neonate in front of us. So, and based on the chart review that we did. So for the blood work, for the blood gases, if we need to adjust our ventilation settings, or if our tube was in proper position or not, we'll adjust based on that. We participate in rounding in the NICU. So it's a multidisciplinary round. So that includes doctor, nurses, RT, dietitian, and we do a full review of each neonate as a team to establish a plan of care. So all the findings of the assessment and the ventilation changed, the blood gases and the auscultation will be brought around, shared with the team, and this way we can establish as a team an approach to following the plan to get the neonate on track and better. So throughout the day, the RTs will follow through the care plan that was established on rounds. Rounds typically happens in the morning. Surfactant is also one of the big responsibilities for the RTs. So once we determine as a team that baby needs surfactant, whether this is in the delivery room or the NICU, the RTs will prepare the surfactant and prepare the necessary equipment for the right procedure. So where I work, we use a lot of mist. But it depends what you're preparing for the technique that you're using between mist or Ensure. Depending on your hospital protocol, so there might be just the RT or the MD and the RT. What did you say, Homa?
I think you're muted, but now we can hear you.
Okay, now.
Yeah, it's short.
Okay, now
the lesson.
That's okay. I'll start back up from this slide then. So the surfactant administration. So as a team, it's determined that baby needs surfactant. We will then, like the RT will prepare the surfactant and prepare the proper equipment to administer the surfactant. So it differs a little bit between like mist and Ensure. Depending on the hospital protocol for the administration, you'll either have the RT or the RT and doctor present for the administration of the surfactant. And once administered, the RT will will stay by the bedside and look at the oxygenation and the pressure very closely, because we know that administering surfactant causes drastic changes in your pulmonary pressure, your oxygen requirement, and so we want to wean this as quickly as possible for what baby is tolerating. We'll also continue to evaluate baby post-administration of surfactant to determine if they need redosing or not. So like I was saying earlier, the respiratory therapist works all over the hospital, and we respond to all critical or potentially critical event. And so this goes even before a baby is admitted to the NICU. So the RT will be part of the team that attends high-risk birth. So just for example, all the premature infant, if the need for vacuum or forceps in a birth is needed, if there's any unplanned C-section or fetal deceleration, anything that has higher risk for the birth, the NICU team will be called, so which includes the neonatologist or pediatrician, the nurse, and the RT. If baby needs resuscitation upon birth, then the RT will be initiating suctioning and CPAP or positive pressure as needed. So this is just a very quick overview of the profession of respiratory therapy in Canada. So really the important part is to use your team. And I know you guys don't have respiratory therapists, but you have your resident, you have your nurses, and a lot of people with a lot of experience. So working as a team is always the best way to ensure best care for our patient. So I hope you all enjoy learning about respiratory therapy today.
Thank you very much, Justine, from your impressive lecture. That was very nice to hear from you. Unfortunately, in Iran, we don't have a nurse that would be special for respiratory therapists. But we have some trained nurses that in each shift, they are responsible for this, but they are not attending for this work officially, you know. We have this problem in Iran. Well, I would like that from the audiences, especially from Professor Heydarzadeh, the previous head of neonatal education in Iran, if he has any comments or if he has any suggestion for our session, I would be very delightful. Professor Heydarzadeh, do you have our voice?
Yes, I have your voice.
Very old. You know that Dr. Heydarzadeh, it was a great honor for me that I was his first student. And it's all the time a great honor for me. Well, go on, doctor. We are waiting for you. I think that you have our voice, yes?
Yes, I have your voice.
Right. I would like that to hear that you share your experience in Zahedan with me.
Yes, actually, um, we have a great experience when it comes to Lisa or mist. We call it in Iran Lisa, I think. And almost all of surfactant administration in Zahedan and also in Mashhad University is right now Lisa, and we have a good achievement in this regard. Especially, it is not just about more than 28 weekers. We use it even for less than 28 weekers, and it is so great for us. And as you know, in Zahedan, before we used Lisa, we had a high rate of neonatal mortality after using surfactant, but after that, we um, achieve a great rate of surviving babies, especially not just all of extremely premature babies, but 26 weekers and 27 weekers. We have a higher survival rate in extremely premature babies. I think the most convincing reason for higher survival rate for Lisa in Zahedan right now is because we do it in the first hour of life after starting CPAP, exactly after birth in extremely premature babies. We had a proposal for the first hour of life, and um, in these tiny babies, we start CPAP exactly after birth, especially less than 30 weekers, and uh, we um, uh, we have almost all of them, and so a rate of these tiny babies is right now is very high in our region in Imam Ali Hospital right now, and we have no problem right now. We had no laser catheter, but what we used um, a tiny catheter for feeding tubes, especially a gray one or uh, green one, and we had a very good result in surfactant administration with Lisa right now. Do you have any question in this regard?
Thank you very much. For which gestational ages do you use it? For all of them or for special gestational ages?
Even for 25 weekers. Yeah. Uh, if you um, administer surfactant after starting CPAP at first hour of life, it is so easy and it is fantastic because you don't lose any babies in this case. I think I would like to mention a comment in this case because we had we have no respiratory therapists in our country. I would like to have the curriculum of respiratory therapy in our country. One of biggest struggles in our country right now is because we have no respiratory therapists in our region. I know that a few hospital in our country have one, one sort of respiratory therapy, not officially but in action. I would like to have a degree in this regard if it is possible. Maybe our colleagues in Canada can help us in this.
Well, I will. I should ask from Josin that do they have any curriculum for this? If they have, can they share it with us or not? That we can use in Iran too. Well, I would like to pass the microphone to Professor Sadeghi Muqaddam. She's the attendant of Tehran University of Medical Sciences, and she's beside me. I would like that you have some your own comments too, Professor.
Hello, and thank you for very nice presentation by Dr. Da Silva and Justino. I hope that this webinar be a startup collaboration between Iran and Canada in educational and research area. The data that presented by Dr. Afkhaminia was for about 3 to 5 years ago, and now we use Lisa or Miss method more than previous. I have a question from Dr. Da Silva about this problem. In guidelines, there is no clear indications or threshold for administration of surfactant in late preterm babies and term babies with secondary surfactant deficiency. About 15% of our late preterm babies had received surfactant. What is your idea about indication of surfactant administration in late preterm for RDS and term babies with secondary surfactant deficiency?
Thank you for the question. As I mentioned before, we treat RDS regardless of the gestational age. Of course, as the gestational age advances, the rate of RDS reduces. In the term babies, 1 to 2%. But if the mother had diabetes and diabetic moms, those babies are at higher risk. And we'll treat the disease regardless of the gestational age. If you have RDS, clinically diagnosed RDS on a baby that is, say, 35, 36, 37 weeks, we do give surfactant. Having said that, because we know for those babies, RDS is a self-limiting disease. Usually after 72 hours, they go into a diuretic phase, and they do get better by themselves because they're going to turn on the surfactant production machinery and produce their own surfactant. We wait a little longer, as Dr. Muhammad presented, that he uses LISA on very soon after birth, and he's absolutely correct. The sooner you give the surfactant, especially to the very tiny baby, the better. There is good evidence out of Germany that it's not prophylactic, but they call it quasi-prophylactic. The sooner you deliver the surfactant, the better. Whatever technique you use, either Ensure or LISA, but I'm specifically talking about LISA. Now, let's go back to the late preterm baby. If they do develop RDS, we tend to be a little more tolerant of waiting a little longer. We wait until they are on more than 30% oxygen, for example. Because quite often we have babies in my unit that have developed RDS, they are 25, 26, 27% oxygen. We do a chest x-ray, has mild RDS, and the baby's clinically well, we may wait it out. And until within a day or two, they resolve. But if they do meet criteria, if they do have RDS, gestation age is not a limitation. We'll treat the disease regardless of the gestation age. And as I showed on our data, we did have babies that are 35, 36 weeks, but those are fewer baby. And for the other conditions, meconium, pneumonia, pulmonary hypertension, and we treat, again, we attempt, but quite often they don't respond very well. But we treat the disease on regardless of the gestational age. But you can wait for, say, a 36-weeker that has mild RDS. It's going to resolve eventually. And those babies have low risk of mortality, low risk of BPD. So we don't need to be as aggressive as we are with the very small babies. Either LISA or Ensure, we try to give surfactant very quickly after birth. This is the difference of the approach on how we treat these babies, depending on the gestational age.
Thank you.
Thanks a lot for your comments, Professor Da Silva. I would like to thank especially for you, especially that you are on duty tonight. We all know, neonatologists know that what does duty mean. Well, thanks for your lecture too. I would like to want that if it is possible, we have the curriculum of the respiratory therapies. If it is possible, you share with us that if we can, we train this part in Iran because we don't have this part, and maybe it can help us for decreasing the mortality. I would like that if anybody else has any more question or not. If there isn't any more question, we would like to end the session and say goodbye to everybody. Well, I think that there is no question. Nobody raised. Oh, there is one. Fazullah, right? Dr. Fazullah. Dr. Fazullah is our fellowship. Yes, Dr. What you have word? Whoever asks question, they can open their microphone and they can ask, because you can open by yourself if you have anything. What? چه مطالعه‌ای در ارتباط با
مطالعه در رابطه با مسئله ویزا وجود داره.
in Iran, she asked how many there are how many studies in Iran. I know that one of the first study was with me and Dr. Haydarzadeh, and I think two or three more study there is. Maybe Dr. Sadr, yeah, 2 or 3 studies there are in Iran. Thank you very much. I think there is no more question. Well, I would like to say goodbye to everybody and thanks you for your joining to this session. See you again. Thank you and good night. Good night and good evening.
Thank you.